I'm Jim Leahy. I'm moderating this session, and with me for this are Drs. Brian Birch and Hiro Lavagna, as well as Scott Kirby from PCC. I'll let them do some introductions in a little bit here, but we will go ahead and get started with some of the basic session goals for this panel. There's been a lot of conversation on PCC community and just in general about AI tools in the industry, and so we're going to spend some time discussing various AI tools and their purpose. I'll be really turning it over to these guys to lead us through a discussion of that, with the questions that you folks have, of course, help guide this session. We'll throughout probably explore some risks, challenges, considerations for using AI, and investigate maybe a little bit of the future outlook of AI tools in peds. Scott and his team shared some information yesterday as part of what's new and what's next regarding AI tools. So he's also going to be here to answer some of those questions about what we're looking to do and reinforce some of that messaging. So yeah, those are the goals. Yes, Kate.
If you have a question, please raise your hand and wait for me to bring the mic over to you so that the folks streaming can hear the questions. Thank you.
Yeah, thank you, Kate. So no free-for-all. Alrighty. So uses of AI in pediatric medicine or medicine in general, we're seeing lots of conversation right now about ways that AI might be used, ways that AI is being used already within pediatrics. But we start thinking about ways that it might be used. Everything from diagnosis and early detection, personalized medicine, behavioral mental health, admin tasks, education, training, research, and data management. The uses of AI right now are blowing up. I know that educational institutions are grappling with, how do we manage, the use of AI in assignments, trying to get ahead of these problems as opposed to, falling behind them. So we know that, AI is here. It's likely here to stay. And so the question becomes, how do we utilize it and how do we make use of AI? We know that there's a number of AI scribe tools that are out there. We've seen things from Deep Scribe, Free, Suki, others that we've looked at as well, and everything from transcription, summarization, organization of notation, are all things that are attractive to pediatricians and really anybody who's working in a job where there is some amount of notation that needs to be summated and organized here. And there's a lot of not so obvious uses of AI. We think about beyond just filling out your note, what about the idea of predicting no-shows or late arrivals based on behavioral patterns of patients? The idea of AI-assisted staffing and schedule optimization, customizing educational materials for parents and patients, monitoring provider burnout through EHR interactions and analytics. If you're clicking something consistently and this is really driving you nuts, can AI pick up on that? What about prior authorizations? I was talking with somebody yesterday about how challenging their referral process is. I'm sure in a heartbeat, if they could speed up some of that process with AI, they would do it. Detecting billing anomalies or fraud. How many times have folks reached out to PCC looking for some reporting and some analytics on what's going on inside their practice because they suspect there might be some fraud involved? What about the use of AI in that regard? So there are tons of places where it potentially could be used. And we know that where is AI headed? We're already seeing, EHRs and, in fact, pediatricians using AI, inside the EHR in tandem with it. And I think that's, what we're going to spend a lot of time talking about in this session. We think about, patient risk stratification at the population health level. Ways to manage and evaluate data are huge with AI. Decision-making support, I know that's something that we've kind of stepped a little bit back from at this point, but we know that that's a place that AI could be headed as well, and so it's something important for us to consider and continue to evaluate. We know automation in terms of billing, reporting, and the like, and then with practice ownership support, optimizing your payer mix, staff utilization, patient flow, tons of areas where AI could be utilized in the future. But really, this discussion is about panelists sharing their experience and you folks asking questions about how AI is being used, sharing your experience as well. So I'm really going to turn it over at this point to our panelists to talk through some questions. We've curated a few, but really open it up to you folks in the audience to ask how AI is being used, what those challenges are, how they've gone about training on it, what they've used. So we'll use this as really just an open conversation. Before we dive into questions, though, I'd love to introduce the panelists, and we'll start at the end of the table here.
Hi, I'm Hiro Lavagna, and I'm a pediatrician in Cumming, Georgia, 2-provider practice.
I'm Brian Birch. I'm a pediatrician in Meridian, Idaho, 2-provider practice.
I'm Scott Kirby. I work at PCC doing stuff with our clinical data exchange team and have recently been working with our AI research group as well.
I really don't need that. I mean, I might not need a microphone anyway. At any rate, in terms of questions, I want to talk, for starters, about AI utilization integration, and maybe you guys could tell us a little bit about, the tools that you're using right now and piloting in your practice for AI.
So I'm using an AI ambient scribe called Empathia, and use it in a couple different ways. So one is direct patient care, ambient scribing my note that then copies and pastes into PCC. The second thing that we've started doing is taking outside records, bringing them into the AI model and having it create a summary of those outside records so that I don't have to read an entire epic note. I'm able to get the highlight of that visit in a quick summary form.
So I am using ambient scribing with Scribeberry, and I use it like Brian for notes, but then I also use it for care plans. And so if I'm in a mental health visit, I'll get my note and then I'll ask Scribeberry to create a care plan for me, which I just copy and paste into the care plan. And then at the next visit, I copy and paste that same care plan and say, this is what we did on the last visit. I even include medications that haven't worked so I can keep a running list of things, whatever side effects the patient had with previous medications. And then I also ask it to write letters for me as well. So 504 letter requests, letter of medical necessity, disability letters, and things like that.
Yeah, so those are two interesting scenarios that I think you guys have talked about in terms of, well, one summary of a medical record, Dr. Birch. Tell me a little bit more about that in terms of you're feeding this information in, and then of course it's kicking out a summary. How have you gone about kind of sanity checking the information that's there?
Yeah, I mean, so hallucinations is a big issue. Obviously, missing data is a big issue. So we've been doing this for about a month. In this last month, I've been doing kind of some QI or QA with looking at the summary and still looking at the note, and have yet to come across an issue where something that was hallucinated, which I think is far worse than something being omitted, omitted. But and then on the other thing that we have built in is our workflow has it so that the note still is there. So if I look through and I'm still confirming with the family, like, oh, I saw you saw Dr. Burpee, the GI specialist, and he wanted, he increased the ciprofloxacin last time, and they're like, oh, and he also did X, Y, and Z, I can then pull up the actual note still right there in real time. So it's not only, I still have the original document if I need to go back, or if I look at the summary and I'm like, it doesn't seem right or something's missing, then I can still do that.
Okay. Yeah, and then Dr. Lavanya, you were talking about the idea of, generating letters. Tell me a bit more about that process and how, you're doing that.
So normally what I do is it's in the visit. So I've already gotten enough information from the families, and then I just kind of tell AI to create the letter, and then if there's something like it starts hallucinating, I say, well, I just write, that's not true. So, like this part is not true.
Wrong.
Or if sometimes it gets confused by who did what recommendation. So sometimes it thinks that the parent recommended it when I did, so I have to clarify that. Other times I'll just edit it within the notes, so it does learn if I'm editing within the AI program.
Yeah. There's a question over in the audience.
And I have several from online.
Perfect. Start feeding them.
So how many AI platforms had you tried before you landed where you are now? And what made you switch from any prior attempted trials to where you are now, and differences amongst them?
So I tried 2 or 3, and most of them only allowed me to just scribe as without letters or care plans. And so Scribeberry was the first one that allowed me to do that. Now, I have tried the one that Brian has, and that one is really cool. So I may switch over to that one, but I've only been using that for about a week.
So I've done 8, 9, 10 different ones. I started off on Deep Scribe that required a 1-year subscription when I opened up my practice. At the end of that year, I was asked to do a presentation at this conference, and so in anticipation of that, I went ahead and knowing that I didn't want to be stuck with a single, another year-long contract, I went ahead and started exploring anything that I could get a free version of it, and then ultimately did a few and then of those I spent considerable amount of time on 3 other platforms before then ultimately doing Empathia.
Brian, where did you learn from?
So I'm using what's called Empathia.ai. EMPATHAI.ai.
Kate, you had some questions that were
Yes,
coming?
some online questions. Angela asks, may we use AI billing companies to save time and to batch claims? Last time I looked into this, about 6 months ago, I was told that it was against PCC policy.
Yeah, Scott, do you have any thoughts? Or
I made the
on
same
that front?
face.
I need to know a little bit more. I think I wouldn't say that we have a specific policy on what folks can and can't do with their claims in that regard. It might be against our guidance per se, depending on our knowledge of what tool you're using, the general sort of evolution of AI-based RCM tools and similar stuff. I'm looking at Justin Blue in the crowd, you want to come and talk? No. But yeah, I mean, I think talk to us more about it. But the question I would have as an interoperability guy is, in what way would that AI tool set batch claims for you? We're not going to plug it in unknowingly to PCC at least.
Right.
Several more from online, if that's all right. Or do we have an in-person as well?
I was going to say, I can tell you from the sales side of things.
From the sales side of things,
Out there that we know of.
there's a company out there that we know of that uses AI for batching claims.
Huge problems with AI.
Huge problems with their AI.
I don't want to name any of them, but
We won't name names at this time.
against it at this point.
Yeah, sounds good.
I appreciate that insight, Scott.
Yeah, I won't name them either. But in general, we are keeping a pretty close eye on, when you're using AI-related tools for financial transactions, there's a question of who's liable if you do something wrong, right? So you ultimately are still on the hook for making sure that you're batching claims correctly, coding correctly, et cetera, et cetera. And yeah, I'll cut off my RCM talk there.
Next question, is it ethical for healthcare providers to use AI tools in patient care without informing the patient? Should patients have the right to know when AI is being used in making decisions about their diagnoses or treatment?
This is not legal advice. Contact your lawyer, and it's going to be state specific. So Idaho is a one-party state, so you can legally record somebody without their knowledge. That being said, we ask for verbal consent with our visits in my practice, but every state's going to have a different legal requirement, and then beyond the legal requirement, I think ethically is a decision that you individually in a practice would have to make.
I have my own question there. You said you obtain verbal consent. Is it from the patient, the family, both? And do you flag the patient to indicate that they have given consent?
Yeah, the family. I'm like, for new family, like new patients, new families, I'm like, oh, and I have a virtual AI scribe that I use. If I'm going into a conversation that might be a little bit more sensitive, I ask specifically in that situation, like, hey, I have this AI scribe. Do you want me to turn that off for this conversation or not? But laws are going to be different based upon your jurisdiction.
Georgia's the same, so we have posters in every room explaining what AI Scribe is and how we use it. But that being said, if there is a very sensitive topic, then I reiterate that we use an AI Scribe, and if they're okay, and I just explain it.
I also don't put full PHI information in the AI Scribe software. So I do have a BAA, it is HIPAA compliant. However, I don't go and put, Perry Birch and a date of birth. If I'm seeing Perry Birch, my daughter, then it's just, I don't see my daughter, but it'd just be Perry. So there is some protection there, even though there is a BAA, it's HIPAA compliant. I don't go and put Taylor Swift on there.
The next one is, what happens if a patient explicitly refuses the use of AI in their care, but then the provider uses it anyway? Does this violate patient autonomy or informed consent?
Yes. If somebody asks you not to do something, you don't do it.
Yeah.
All right. I feel, Hero, same answer? Yes. Okay. I swear, I've got 2 more onlines, and I'll grab you, Melissa. Considering that digital data is never truly deleted from the internet, how can we ensure that AI tools used in health...
It happened to me in the earlier session, so you're not alone.
Considering that digital data is never truly deleted from the internet, how can we ensure that AI tools used in healthcare protect patient privacy? What safeguards are in place to make sure patient information isn't permanently exposed or misused?
Yeah, again, I do the same as Brian. We don't put first and last name and date of birth. It's really just a first name. Sometimes it's a nickname. Sometimes there's not even a name. Yeah, so a lot of times you don't really know who this patient is. All we can do is just base it off HIPAA and BAA. I mean, we do that every day with other vendors, so why not AI?
And the last online one for now. Aren't we concerned with the source of all AIs? Out of state or regions concerns? China, question mark?
No.
I don't. I need to get more details on the concern, but large language models can be hosted by any number of actors in any number of places. You can, some ambient scribe vendors that we've looked at in our research can give you an entire sort of supply chain of every bit of technical component that they have and where it's hosted and all of that. So I think the real danger is the seltzer bottles, right?
Right.
A robot wouldn't do that to you.
Yeah. So I guess just in general, I'd say it's good to know about the technological underpinnings and who's hosting your stuff. But it's not as though even if someone in China produces an excellent large language model, you can host that large language model trained as it comes elsewhere and not have it be sitting on some server in a different place. That should be covered in your BAAs and your technical use policies and such. Yeah.
Yeah, so I think to expand on that, I think there is due diligence that needs to be done when you're choosing a scribe based upon their privacy policy, the BA that they're going to sign with you, what information they deem shareable versus not shareable. And there's very, very different versions of how this is done, from you end your session and all data's wiped to we own the language model that is being used and the learnings of you doing this, we own those learnings, all the way to we own unidentified health information that doesn't break HIPAA because it's PHI excluded. So there's different versions of privacy, and that will be dependent upon you as an individual as well as your organization's policy on whether or not you will subscribe to services that may share de-identified health information or not.
I actually have a comment and a question. My comment about the AI scribe companies, there are companies that actually work on the back end of them to provide them security. I happen to know someone who's doing a startup, of course, but I live with an AI expert. The question I have for the physicians is, how much time do you think it saves you using a scribe?
So Empathia keeps a timer of what they expect based upon their research, what they expect you to save. I think my counter's up to like 240 hours in the last year of what they predict my time saving is. I started my clinic with using AI Ambient Scribe, so I built 100% of my visit, 99.8% of my visits are using an Ambient Scribe. Well child checks, sick visits, behavioral health. More value in things like behavioral health visits than and time savings than I would say like a wellness visit or a sick visit, particularly if you have excellent templates that you like to use. So it's highly variable. The other benefit is for a provider that sometimes gets distracted by other needs of running a business and not closing your charts instantaneously or right afterwards. All the data's there, and you pop it up and you review it, and you're like, oh, I'm gonna make this one change. Even if it's a few days later, you're not going back and being like, I know I saw that kid for an ear infection, but was it the left ear or the right ear? Oh wait, he's allergic to amoxicillin, so what did I use again? And you're trying to dissect the visit from the discrete data you've put in. It's just all there. You verify its truth, and then you move on.
So I did not open my practice with AI. I just started using it a year ago. So I just use it to copy and paste my history and my plan. But with my mental health visits and the, oh, by the way, sick visits, I would say I probably save 1 to 2 hours a day.
That is significant.
Can I ask a follow-up on this?
Question.
Yeah.
Something we've been hearing a lot, probably from you guys as well, but from all the clients we talk to, is that it's not strictly the hours saved, but also just the level of engagement that you can provide in the visits. Are you guys finding that there's a benefit there as well, and that's a driving force? Or?
Yeah, I mean, when you're not stuck behind a computer having to click buttons, like I walk in for a quick ear infection, I use laptops, I put my laptop down, I'm washing my hands, I'm like, hey, I heard you're worried about an ear infection, tell me, and I'm washing my hands, I'm getting the history while I'm washing my hands, I'm getting the review of systems done while I'm examining the child. I'm vocalizing so AI will pick up on my physical exam, the key components to it, and then I'm finishing up the visit, educating in and out of the room, and I'm not even on my computer until the very end when I click the left otitis media left or bilateral and write the prescription and move on. So it allows me to engage more with the family, but it also allows me to multitask, not in I'm multitasking while using the EMR, but multitasking while examining and playing with the kid and having that interaction and engagement. And families, the response we get from families is it's highly valuable, that they're like, oh, Dr. Birch is so nice. He always likes to play with the kids. And I'm like, yeah, because I don't have to have my nose stuck behind a computer screen during our visit or spend 5 minutes after every visit with my nose at the computer screen.
Same for me. I really pre-click and post-click, but in the room, the only time I'm really clicking is if I'm working on a prescription, just because I need to know what pharmacy they want it sent to, and they're going to forget and say, no, I really need it sent to the other pharmacy. So all that happens in the room, but there's really little clicking. And I mean, it's been a game changer with my mental health patients. Like that anxiety or depression initial, just being able to sit there and make eye contact and not have to remember that, oh, I need to type all this down because I'm going to forget some of this. That has really changed my life.
Now, one thing I'm curious about, as a follow-up to both of you guys. Now, I keep trying to give her the mic. Why don't you start, and then I'll come back to my question.
Sorry,
No, it's okay.
Sorry. Okay, so I also have a comment and a question, or just a statement. I've been using, I don't know if anybody else is part of the Doximity beta, but their intent is it is free, and they're intending to keep it free. So if there's a way that you can finagle becoming a part of that, I highly recommend. That said, I will definitely be checking out a couple of these others to see if they cover areas that maybe I'm finding a little less effective in Doximity, but just wanted to let you guys know. My question is, given our wonderful templates in PCC that we spent hours and years and months building, I too am just cutting and pasting into HPI an assessment and plan. What are you, like, are you just forget the templates and just your well check exam and everything is just going to HPI basically and you don't even use the template?
Yeah, so I just have a template section for every note that's it's just a SOAP note. And it's just, I'm a lumper, so it just lumps in there. And then I have it set up where, like, above that is where the vitals are. So if you were to print my note and look at it, you'd be like, it's not pretty. Like, the vitals aren't in the right section, right where the physical exam is. My physical exam, I use templates within the AI so that if I'm doing a well child check, it templates my exam, and then it has a findings as above unless otherwise stated, and I've trained the AI to put then the abnormal findings there, so that I'm being consistent. You have to learn how to vocalize your exam findings so it goes into your left ear, bulging in red, but otherwise looks good. I have snap texts for like basic exams and stuff that I always do for even if it's just an ear infection. I'm always looking at these things, so that gets put in.
From PCC that you incorporated into your custom AI?
Yeah. So I just use snap text. So I'll go in. So there's two ways of doing it. If you edit within AI, the AI program, depending on what the program is, is machine learning that starts to learn your style, and depending on your vendor, they may have what's a personal profile for you. So with Empathia, somewhere in the background learning, they have Brian Birch's personal profile of all the edits I've changed. So when AI did this and I'm like, I didn't like that, I made the change, and it learns over time, like, don't do this. He always corrects that and does it this way instead. Not all AI is built that way. Some of them just have general machine learning and general profiles, or profiles based upon your specialty. So those are things to look into as well. If you go and copy and paste into PCC and then edit there, AI won't learn. But sometimes in some situations, it's just easier to copy and paste into PCC and make a small little edit there than it is to change it within the AI, and then, or you've copied and pasted it and then you're like, oh, I didn't see that, let me change it here, as opposed to going back and forth.
Does it learn your plans, or does it
No.
insert its own plans?
No, so I think that's the most dangerous thing about AI is hallucinations.
It does not learn your plans.
Yes, it does not learn the plans. And you don't want it to learn your plans because your plans aren't the same for every patient. But you as a clinician have to learn how to vocalize your plan. Luckily for us as pediatricians, we're obviously, whenever we have a plan, we're educating the family on the plan, and it does a very good job of picking up what that plan is.
You just have to get rid of the other stuff because that's what,
Yeah, and so there's splitters and lumpers, and I've had conversations with the PCC tech people about this. If you're a splitter and you're creating something like this that's made for lumpers, they're not going to be happy. And if you have lumpers and you're creating it as a splitter, you're not going to be happy as well. So you need to take that into consideration as you're building and potentially integrating this in. So yeah, so you copy and paste two sections I just copy and paste one section. Somebody else out there may be like, oh, I'm going to copy and paste 5 or 6 sections into discrete areas. And that's where I think the challenge with PCC is going to be of saying, okay, what's the minimal viable product? That might be the lumping product because that's easiest. But then how do we then eventually move towards something which helps the splitters that say, hey, I want this data to get pulled out of the AI and discretely go into this. So like for you, like if you're PCMH and you're like, hey, when I talk about the care plan, I want that data to discreetly go into the care plan area for PCMH in my template. That unlikely will be a MVP product, in my estimation, but it would be an eventual, oh yeah, can we train AI that when I say, okay, let's talk about the care plan now, and that's the prompt that AI then picks up on to say, oh, anything I talk about now goes into the care plan, that then it would move into the care plan.
Does it affect the reports you can generate? Sorry, too.
Does this affect the reports you can generate?
Like how many depression screens?
Like how many depression screenings you've done?
So we still put in discrete data. So depression screening, Chattis, developmental screening, diagnoses. I still click the buttons for diagnoses. It's amazing, like a well child check, where it's like, yeah, I'm doing a well child check, and AI picks up on, oh, I talked about constipation, I talked about this. I might not have supersized that visit as far as a billing perspective, but it actually is really intriguing how much we do beyond wellness care. Even in wellness care, even when you're like, oh, it's not that big of a deal talking about night terrors, and it's like, and then you look at your note and you're like, oh my goodness, like, yeah, I obviously, here's a whole big old paragraph on all the things we talked about night terrors for this 3-year-old. I'm not billing for that separately, but it does justify a little bit of like, oh yeah, you do a lot more than what you think in just a wellness visit.
Yeah, I was just going to say, when Dr. Birch told us about his lumper manifesto, when we were first asking him, talking about the AI scribe stuff, it kind of blew our minds. We had been really racking our brains, especially when looking at either building something internally or partnering with a vendor, how to best support the varied and robust sort of protocol configuration that exists in PCC EHR with all those different fields, the components you can add to your protocols, and how to make sure any structured data we'd get back from an AI integration would map to that. And then he was like, "Oh, well, you don't have to do that for me. Well, we get this right here. It's a big summary. We put it right there, and so on and so forth." And really sort of showed us that there was an additional element of complexity in anything we would deliver, and that we did have to think about supporting both the lumping and splitting, which I think is a great way to describe it. And having as much or as little granularity of structure being returned as possible. So that's big on our minds as we're looking to move forward, for sure.
We
Dr.
could call the
Levine?
first product Lump. Here's our
Lump
next
by
question.
PCC. Sorry.
And then split.
Okay, well, I'm glad Kate was sitting next to me because my question actually has to do with the lumping and the splitting, which I was not understanding. I've been demoing a few different systems, and one of the biggest issues I have is I don't like how the final note ends up looking when it's generated through AI, because you do have so much of the template that's sort of left blank, and it's all squeezed in at the bottom. So I was thinking that maybe a PCC could have sort of a hybrid protocol where, a lot of these scribes will have templates that you can pick from, and that it basically, it dictates into it. So it's really like a big text box with just like a plan at the end for the sick that you could use, that even though the visit would be picking one template, you just go and you switch it to a different protocol, and it would be the AI protocol, so that it would look so much better. I think that everything you're saying makes me feel convinced that I want to use it, except how the note looks in the end. That's really what's been my stop.
So I would recommend creating your own personalized protocol to test this out on, and say, I'm just going to do this for some behavioral health visits, and I'm going to create a protocol in PCC that I'm going to name AI behavioral health, and then just have your one big text box, and then everything else isn't even there in your protocol now, and it looks a lot better. From starting from the reason why I invested in Deep Scribe from the beginning is I was like, I think this is coming, this is going to be big, this is the way I want to practice, and I don't want to invest all this time creating templates that don't work with AI. So I started from scratch just using templates, like bare bone templates, because the bulk of my data is getting put through that SOAP note one section, and then just the discrete areas that are needed, vital signs, essentially diagnoses, vaccines and stuff, are then put in are in my template. So my template, if you looked at it, is very bare bones.
So your templates are basically all AI?
Correct. My templates, because I never invested in creating traditional templates, are all AI optimized.
A friendly PCC reminder that the way in which you name your protocols is visible to portal users in the visit summary and visit history. We do have a new functionality for portal user self-scheduling where your protocols can have an internal view. So something maybe like sick, contagious, exclamation point is your internal view. And then the external is sick dash fever, so that mommy and daddy aren't picking sick, contagious.
I think you're speaking specifically about visit reason.
So that
not
difficult patient template
Sorry,
that I
visit reason.
created shouldn't
Yeah.
be used.
Right. So
Joking.
I know because I giggle at my pediatrician who uses PCC. When I look at my kids' visit histories in the patient portal, I'm seeing either some cute visit reason names or protocol names. So just keep that in mind when naming things, is what I'm trying to say. So we should consider that. Note for PCC, really. And next question.
So I've been using Freed for a while, and the biggest hang-up that I have is if I'm not smart about when I end the visit, I'm outside the room waiting for the 2 or 3 minutes for it to transcribe and compose something, and then I'm deciding, well, do I go to the next patient? Do I wait? And that's the hardest workflow space for me. How do you handle that?
So if I'm on top of things, I do exactly what you try to do, which is I try to get the note transcribed, edited, and put in the note so I can close it and be done. On days where I'm running behind and I don't have that couple minute wait, then I'm just finalizing at the end of the day. My Empathia had a recent update which sped up that transcription time, and I think that's something that you're just going to see across the board coming over the months to years, is the time it takes to record, transcribe, and then create. That time is it's not going to be like AOL dial-up. It's going to be faster and faster. So I think we're going to see, I think that's a temporary roadblock, but I think the technology is getting better and it's getting faster and optimized where that's going to be less of an issue. But yes, exactly to that point.
So I will usually just stop recording and press generate as I'm saying my goodbyes. And then when I get out of the room, if I have time, I will copy and paste and edit and everything. If I don't have a time, I'll just copy and paste the whole thing into my HPI and fix it later.
So I have 2 questions, if that's okay. One is more perhaps equipment-based or tech-based, but we've been using Freed a little bit in our office, and more of the clinicians are using it. And our advice nurses have recently asked if they might be able to use it. And I'm curious if any of you have used it on the phone or with any kind of adapter. Are you aware of any way to use it on the phone?
I've used it with a speakerphone in my office, and I use it for telemedicine. But
Yeah.
I don't know about like actual phone.
Yeah, I've used it for telehealth visits quite frequently. The only issue that I've had and I've read about in some, depending on programs, is the microphone for like your telehealth overriding the microphone for the AI. And so a phone, that might be the same issue. It might be where even if you're on a cell phone, you might not be able to speak and have it capture at the same time. The option would be having it like on a speakerphone, but that would may be disruptive to workflows.
Yeah, that's what we've done for telehealth, and we have 2, a computer we're doing the telehealth on and another that we're charting on, so that's how we've gotten around that microphone.
Yeah, I haven't had actually any issues with using our technology with AI scribes and doing telehealth on a single laptop.
Yeah.
And Scribeberry has a button that says telehealth, so whenever I click on it and record, it asks me which tab is my telehealth tab, and it just connects to it. So it integrates. in Chrome at least.
If it's okay, my second question was just about, Brian, it sounds like you looked at lots of different ones. I assumed you looked at Freed and are all the same thing. What made you choose the one that you chose? Was there any feature in particular, or?
Yeah, for me, it was a combination of features. So my first advice is don't marry your AI scribe date right now. So don't sign long-term contracts unless you really, really want to be dedicated to it. I think there's a number of reasons. One is there's so many new features coming out, and stealing of features like this one's doing this, they're keeping an eye on all their competition. This one's doing this, we're going to add that. So things have changed even since I've done that evaluation. The thing I didn't like about Freed is that at that time it didn't allow you to have customized templates, so every note looked kind of the same. So it's like, oh, it couldn't recognize that I like my toddler well child check to have a section on development and behavior, whereas my adolescent well child check, I want to talk about drug, sex, and rock and roll, like heads exam stuff, and have those in discrete sections. And I couldn't do that with Freed at the time. Now I did a recent short trial, and they now have templates. But the things I was looking for was lack of hallucinations was my number one thing. The second was, and I feel like hallucinations more dangerous than omitting something. And I don't know if Jess is here, but I think he left this morning, but he would probably agree with that. But omitting things is still bad, but not as bad as hallucinating. The second thing I wanted was ability to create customized templates within the AI, so that when I talked, regardless of when I talked about things, it would show up in the development section, or it'd talk about the behavior section, or it'd talk about, the school, how school's going, or pooping and peeing. So I wanted customized templates. And then the third thing I was looking at was then what's other ancillary features, being able to create notes. I like the ability to do smart edits, where rather than going and making small little changes yourself, you can smart edit and just say, I put in the wrong pronoun, change pronoun to he, not she, and then it just redoes your note for you. And so what I found was, as I was going through, Empathia had hit all the check marks for me. And then over the last 10 months now, because I started it right after NCE, it has continued to meet my needs and add additional features, like bringing in PDFs that then you can create a template for it to summarize for you.
All right, we've got another question over here, and then I'm going to circle back to the chat because I saw quite a few happening on my screen.
Okay, so I currently use Freed, and I use it in my acute visits only, because I found initially, like you said, you couldn't build templates in Freed. Now you can, but for my acute visits, I just built a protocol called SOAP AI, and so I copy and paste everything into one box, and it really separates it actually kind of nicely. In Freed, it lets you build a base physical exam. So it'll report a normal physical exam unless you specifically mention something about that system, which I kind of like. I'm interested in the Empathia. And my question to you is, if you build a single protocol like the SOAP, the dump, can you can section it off in the note through the AI, like nutrition, sleep?
Yes, within AI, and I think Freed has that now too. So it's not isolated to Empathia. I know Scribeberry as well allows you to do templates. The only thing is, it will not, like if it tries to bold or it tries to highlight or like red font, that isn't text, that data doesn't get copy and pasted cleanly into PCC, so it won't bold it, it won't make it red. So you have to really just make sure you're copy and pasting like clean text in.
So this is going to sound like a silly question, but how do you, I utilize my templates partly to keep me on track in a visit. You get distracted a lot. Parents go off on like you said, that oh, by the way, he has this, and then I can get off my routine. How do you, as a provider, make sure you're hitting all of those buttons that you need to in your note for Bright Futures well visit?
So the one template that I have that I don't use AI Scribe for is a pre-op visit, because there's so much just like family history, check boxes, you don't want to forget anything. One of the things I like with Empathia is it has a Chrome extension, which is I mostly extensively use. It has what they call Copilot, which allows you to look at your note template. And so, when it's divided up, it's like, oh yeah, I make sure I talk about pooping and peeing and sleep, and it's like, oh, I didn't forget to, mom went off on a tangent and I forgot to talk about pooping and peeing. Let me make sure I add that in. It doesn't add it in while I'm talking, so you have to remember, like, oh, I forgot to talk about pooping and peeing. But it for me, it allows, it's enough of a nudge to be like, oh, I forgot about talking about pooping and peeing. Let me go back to that.
So speaking of lumps and dumps, don't forget poop and pee. All right, some providers believe that using AI makes them more efficient. However, my concern is that if the AI is actually diagnosing patients, then it raises serious questions. If that's the case, what roles do doctors play? With internet access and AI doing the diagnosing, it may seem like human physicians are becoming unnecessary.
Our patients are already using AI coming to us with a differential. And sometimes it's helpful, to be honest with you. So they're coming in for chronic stomach pain, and you're talking about this, and this, and then you can tell, it's the equivalent of, oh, I Googled this, and I'm worried about, hepatic carcinoma in my 3-year-old. They come in now with ChatGPT saying, here's the different, and they have the differential in front of you. So AI is not going to replace clinical judgment anytime soon, if any time at all. But it could, patients that use that, and particularly around developing a trusting relationship with them, it can be helpful. It can be annoying, just like when they Googled their symptoms before they came in, and now they're worried about this. It's the same battle we fought with just an overabundance of information.
What do you feel is the greatest benefit to the provider panel from AI? I feel like we may have touched upon that when you're talking about more human connection time and saving hours. Are there any other benefits you'd like to highlight?
It's just more fun to be a doctor and play with kids than to have your nose stuck behind a computer.
Amen.
No offense to our tech team here.
No, none taken.
All right, I feel this next one as well. How do you integrate your AI-generated note with PCC? I feel like we've covered that. There's some copy-paste, there's some oversight, there's plugins, all sorts of cool stuff. And you also have to train it, to understand when you're speaking about physical exam versus diagnoses and plan. Next question, with the rise of individuals who seem eager to file lawsuits, do healthcare providers feel increased pressure or concern about being sued over using AI?
I mean, if you're using AI to diagnose and come up with a plan for you, then probably. But I mean, a lot of people have human scribes, and it's pretty similar. It's just someone is typing what you're talking about in a clear format. So we're not really asking AI with ambient AI to, diagnose and come up with a plan. It's just writing what we're saying.
I think it does a better job documenting some of those things. Like when you're think about your well child check, and mom comes back and is like, well, I didn't do that because I didn't understand, and you can go back to your note and be like, oh, we did talk about it. It's not, I didn't make that up. I think the bigger thought and issue is how long are those recordings discoverable? So, and there's different vendors will have different policies on how long they archive those recordings for the original transcription, the recording, how long they keep it on their server, and then when it gets deleted, because that could be discoverable in a lawsuit if it's available. So that's one thing to think about. Whether good discoverable is like, I know we talked about that, versus bad discoverable, oh, AI said we talked about it, and mom says we didn't, and I don't have a transcript to now back it up. Once again, the reason why hallucination in my mind is the most serious risk.
Yeah. Mackenzie from the AAP shared some great resources. I think they're fantastic, and I'm just going to shameless plug. If there isn't already a community board, like leaderboard topic going on around AI, if we could start one and start to share some of these awesome links from the AAP. Ian, is this a question or more just, okay. I think it's more of a statement. I don't think AI will replace physicians in the near future, sort of akin to self-driving cars, which are taking much longer to materialize fully, despite the technology having existed for some time now. Creating an AI doctor which can accurately diagnose a crying toddler in an exam room would be far more complicated and fraught, in my opinion. In theory, it is possible, but the stakes are too high for mistakes, and the robotics technology of performing a physical exam is nothing close to where it needs to be. Having patients perform their own exams with an AI doctor also seems very fraught. I see AI as becoming a support for physicians for clinical decisions, but I think the exam and final diagnosis will remain with the physician for the foreseeable future. Next question is, what is the cost and contract term? And did you trial before committing? It does sound like you both trialed. Date, don't marry. But what's the cost and contract like?
Yeah, so to get back to the previous question, one, I have used AI like clinical decision making, trialing it out. You know, that kid that comes in with two very seemingly random different complaints, like she's passing out and she's having chronic abdominal pain, and you're like, I don't know how these two are connected after getting a history. Throwing that into an AI diagnostic, it didn't help me, but it made me feel better that I wasn't like missing something. So I think that to that point of the comment earlier is like, yeah, I think there's going to be roles for AI helping with this. I think we're going to see roles of AI potentially helping with triage, potentially not maybe replacing nurse triage, but assisting nurse triage. So rather than a symptom checker where they're putting in, it's pretty stagnant and based, there is some out there that are actually already doing that. To the question around cost, yeah, date, don't marry. Empathy is a little bit more expensive than the other ones. I think right now, we're paying like $130 a month per user for that. If you take that into consideration of would you have this or an in-person scribe, that's a huge savings. If you're taking it from we're going to have our doctors be transcriptionists, it's a little bit more of a cost, but there was a comment made that AI is moving from a technology budget into a human resource budget. And I would highly recommend thinking of it that way. At $130 a month, I only need to see less than one patient that month because of AI to make back my cost. So one more patient, not a week, not a day, a month. So if it allows me to see one more patient that month at $130, I'm at break even.
Is anyone aware of a law or laws that protect providers using AI?
No.
The answer is no. Any other in-person questions, comments, concerns, curiosities? All right.
There's one back there.
Yeah, really quickly with the AI, the number of providers, there's no way they really know who it is. So if you have 10 providers but only 8 who are ever seeing patients at once, can you just have provider 1, 2, 3, 4, 5, 6, or?
So the question was, could you just share logins essentially for AI? Most places have terms of agreement that you're not going to share your login with other users. It may mess up your personal profile if you like it this way and this doctor likes it this way. And then companies are getting smarter about this just around everywhere. So like JotForm, for example, has done a really good job of realizing that, we have somebody logging into JotForm from 2 different IP addresses, and they only have a single user license. We're now going to reach out to them and either shut them down or offer their enterprise at $2,000 a month for their enterprise version of it. So there's ways that they can look to say they're sharing a username. So I would advise against that. One thing about Empathia that I also like, though, is they do have a part-time provider, one. So if you have somebody that's just working part-time, it's not the full price, which I really like. The other thing I would say when we're thinking about the comment about dating, not marrying, is all of these AI are trying to get users. They're losing money by providing the service right now. They're losing money with the hope that they're going to sell to somebody at some point or come out top. So Google is the top dog in search engine, right? But back in the day, you had WebCrawler and AltaVista and Yahoo and stuff. These companies are wanting to either become Google or sell to a Google, whoever ends up on top. And so that's, I think, why it's important to date, not marry, because they may sell, and now your terms and conditions have changed, but you're still linked to a contract, and it may not be the product that you signed up for and wanted.
Dr. Birch, you mentioned that you're using AI to help summarize your consult notes. How exactly does your workflow work on that?
I talk to the patient, it records it. I hit end.
Sorry, the consults that you get from third parties.
Oh, so that one we're pulling in outside notes. I have an MA who has in Empathia, it's like $40 a month. So it's a little annoying that I got to pay extra for it, but she's not using all the features, and I'm not going to do this myself. So she grabs the outside record either through clinical data exchange or through the access to our hospital system, imports it in as a document. There's a button you can push that will add it to the visit history and the date, so you can date it for that actual like GI visit. And then she's importing it into the PDF into Empathia. We've created a specific template for a specialist visit. I'm like, I want this information. I want their problem list. I want their medication list. And I want changes between previous visits. And then I want full assessment and plan. I've learned just saying full assessment and plan so it doesn't omit things. And that's all that I have to review. That then gets copied and pasted as a note on the document. So even though the note section is like this big, you can copy and there's no character limit to it, at least not one that we've found. She then saves, so then that summary comes out of what I want, and then that goes in under visit history, and she labels, St. Luke's, children's GI appointment. It's dated. So when I go in and either prep for the day or going in right before I go see the patient, I can just click on that. The note shows up first. If it has everything that I want, I don't have any questions, then I'm done. If it's like, I have a question about something, I can just double click on it, and now the actual document shows up for me to review.
One follow-up, how much easier would you say that is than reviewing the actual note itself?
Way easier, particularly when you get an Epic note that has 4 pages of scribble and then this much of a note, trying to just find it in general. We're starting to do it for ED visit follow-ups as well with a different template because I want to know different information, and on the punch list to start trying to see if it would work is outside records from their previous clinic to pull out immunizations, to pull out chronic diseases, to pull out the critical things, not they came in with a stuffy nose stuff, and that I haven't gone there yet with this, but that's my hope.
Hi. In Chattis, we can develop a narrative based on what the patient said. That Chattis already creates that. And then we can incorporate it into the scribe, and it integrates with the stuff that we dictate into the scribe. And I wonder if you've tried that in any of the systems you've used, whether you've taken the Chattis information narrative and regenerated the note that incorporates the patient's history.
That's actually a really brilliant idea that might fix your note looking bad, is to actually just have a template that you put everything in and then you regenerate the note using AI to make it look pretty. I don't care that much about that, but those that do, it would actually be an interesting experiment to essentially say, here's my completed note, but I'm going to actually just regenerate it in AI to make it look pretty. That actually is an interesting concept.
So we'll do 1 or 2 more questions, and I think.
Yeah, I still use Chattis and I review those with the patient, but I don't necessarily go through them line by line because it's still showing up in my template. So I still have the Chattis integration into my template. It just doesn't look as clean because it's not sectioned off in an HPI section.
I have a question. So if you have, talking about medical records, and I understand coming from Epic or ED, et cetera, but if you have a new patient, say they're moving from one state to another practice, and bringing in the medical records with a vaccine, et cetera, how do you do the same with that?
That's what I want to do. So that's not, haven't done it yet, haven't tried it yet, but it's on the list of like, hey, here's another cool thing we can try this with.
Alrighty, maybe one last question as we wrap up here.
Why don't I check the chat?
Yeah, let's take a look at the chat. While we're doing that, one question I did have as a follow-up, Dr. Birch, you talked about the price, for, Empathia, but for Scribeberry, how much are you paying monthly per provider?
I pay $79 a month.
Okay, and that's per provider, I presume?
Mm-hmm.
Okay.
Yes. But I think it would be cheaper yearly, but like Brian said, you don't want to commit to anything for a year because everything's changing so fast.
Thank you.
Yes, it reads and writes. Yeah.
For Empathia, yes. I haven't come across a ton of other ones that use that feature.
Scribeberry says it can, but I'm still, I was going to test it out this past week, but I was having issues, so I plan on testing it out next week.
Okay. What else do we have online, Kate?
Yeah, can you share AI nurse triage? I'm assuming logins?
I think I just suggested that as a potential case, like use case, not that we're actually using it.
Yeah, it's an option. So I haven't tried it out because that scares me, but Scribeberry has where you can send a QR code or a link even through the portal and have it triage your patient for you, and it gives you the information back. But I don't know, I just can't do that yet.
The next one I think we already have heard the answer to, but to reiterate, most AI scribes record the patient visit, including all dialogue. This brings concerns of certain sources of AI that are not HIPAA compliant. We all agree the consent of the patient is required. Recordings need to have an expiration and a guarantee of deletion. Do you have a business associate agreement with Empathia? And I believe you said you do.
And Scribeberry.
And Scribeberry, awesome.
Yeah, I don't know off the top of my head what the specifics of that are. I know I reviewed it when I signed up for it, and it was acceptable to our organization's AI use. But I can't tell you the specifics of that.
Okay. Kate, anything else online? Alrighty. Well, I think we are at time, and so I want to say thank you to both Dr. Lavagna, Dr. Birch, and then to Scott as well for your insight. On using AI tools, some great advice there too about date not marry, as this is moving so fast, and continue to check back. PCC is going to continue to update on our trajectory and roadmap with AI. So thank you, folks.